Hi, I'm Elizabeth Schoenfeld, and I'm one of your colleagues from the Baystate Emergency Department. I'm also a researcher at the Institute for Healthcare Delivery and Population Science. I know that your time is very valuable, and so we're going to move pretty quickly through this. We're going to be talking about shared decision-making today, and I wanted you to know that this talk is available in audio-only form, so you don't have to be watching it to get the content. I know that your time is very, very valuable, and so we're going to move pretty quickly. I have no financial conflicts of interest. I am supported by a grant from AHRQ. We're going to today talk about what is shared decision-making and why is shared decision-making important for our patients' experience. By the end of this talk, you should understand what is shared decision-making so that we're all on the same page, why shared decision-making is important, and how to do shared decision-making with our patients. This talk has two parts. You can listen to the first one first and the second one when you can. And the first part is about those answers. What's shared decision-making? The second part is how we expand shared decision-making and use the tenets of shared decision-making in each and every patient encounter. So my hypothesis for this talk is that shared decision-making done well will improve our patients' experience. But first we have to get on the same page. What's the definition of shared decision-making? Shared decision-making is the conversation that clinicians and patients have when there are two medically reasonable options. Two medically reasonable options is also referred to as clinical equipoise. The clinician brings their expert knowledge. They bring their understanding of the risks and benefits, the advantages, the disadvantages, the consequences of that decision. They bring that to the patient. They explain it to the patient in words that the patient can understand. The patient brings their expertise. The patient's expertise is in their own body, themselves, their experiences, their lives, what's important to them at any given moment. Often the patients need help in bringing that in because through the years, historically, their expertise in their own bodies has not always been valued. So our job as clinicians is to not only bring that expertise of our own, but to elicit their expertise. And then we have a conversation together and we come to a decision that makes sense for that individual patient at that time. So when we think about classical shared decision-making, we think about two reasonable options and us as clinicians helping walk patients through so that together we are making the best decision for that individual patient. The first question when we start to talk about shared decision-making is, do patients even want shared decision-making? So we did a study in emergency department patients who are commonly our most stressed out group of patients. And we spoke to 30 patients and their family members about whether they wanted to be involved in decision-making. And what we found was that for the most part, people did want to be involved in shared decision-making. Now, there is a myth out there that our older patients, our sicker patients, our less literate patients are not as interested in shared decision-making. So I want to share a short story about a gentleman at Franklin Medical Center. So he was being seen in the emergency department for atrial fibrillation with rapid ventricular response. So not particularly stable, okay? Fairly sick guy in the emergency room and older. And he said this. He said, "Human nature tells me that I want options." But again, you're talking about a professional medical physician and a layman. And he said, "I can't compete with that. The doctors, I'm trusting them totally. Whatever they want to do is okay with me. If they want to involve me, that's great, but I'm not going to push it." What this means for us, when you talk to this gentleman, he actually really wanted to be involved in medical decisions, and he could tell me examples where his doctors had involved him in decisions. But when you met him and you took care of him, he appeared completely passive. And the reason he appeared completely passive is his trust in you. His trust in the system made him appear passive, but he did really want to be involved. And that's something for us to remember, that our patients probably want to be involved, but if they're sitting there smiling and nodding, it's because that's what they have learned over the years, that is their job and that's their role when they show up to the doctor, all right? That was a small study. That was only 30 patients and their families. And so we decided to look at this at a bigger level. And we asked over 600 patients at 3 different emergency departments across the country, Massachusetts, New York, and California, about did they want to be involved in their medical decisions. And we gave them statements and they could tell us which statement most represented how they felt about this. And a small minority of patients said, "I want to make all the decisions." And another small minority said, "I want to leave all the decisions up to the doctor." And everyone else wanted some degree of shared decision-making. One group said, "I prefer to make decisions about my options after seriously considering my doctor's opinion. I want to hear my doctor's expertise, I want to hear the consequences, and I want to make the decision. That sounds like shared decision making. The biggest group said straight up, I want to share responsibility for decision making with my doctor. And then the last group said, I prefer that my doctor make the decision after hearing my input and opinions. Again, shared decision making, all right? And why? Why are we doing shared decision making? Shared decision making at its most basic is a way that we support and demonstrate our respect for patient autonomy. It's a way that we say to people, this is your body, this is your life, I'm here to help you be healthy, but I respect that you get to make your decisions about your body and your life, okay? It just sort of makes sense from an ethical perspective. It kind of goes back to what we learned in kindergarten. It's what we would want or what we do want when we're the patient, and that's what we need to do for our patients, and we're not always that good at doing it. But of course, we practice evidence-based medicine. So what does the evidence show? So this is a very simple study that I think illustrates the benefits of shared decision-making. This one was done in the emergency room. This is called Chest Pain Choice, and as many of you know, we admit a lot of people for chest pain as we're trying to figure out, is their chest pain cardiac? And over the years, who we have admitted has changed. And one of the reasons it's changed is because of shared decision-making. We used to admit everyone, and now we risk stratify people, and we let people go home, and we talk to them about their risk. So this was one of the first studies that helped us talk to people about their risk. It presented a decision aid with pictures that said, this is the chance of this chest pain coming from your heart. Maybe it's 1 in 100, maybe it's 2 in 100. It helped patients see that, and it talked about what we needed to do next. And what we found with this study was that knowledge and accuracy of risk perception went way up for patients. They understood what was going on much better. Concurrently, involvement in decision goes up, of course, because we're soliciting their input, and admission rate went down because what we discovered was that once patients understood what was going on, they don't always want to be admitted. They say, I'm fine with going home. I will follow up with my doctor. I can do this as an outpatient. So this is sort of a very basic example of some of the benefits of shared decision-making that have been shown in the literature. I'm not going to go through these individually, but there's some good studies with asthma. Asthma, of course, is a disease process where adherence to medications is really important. It drives outcomes. And what this study showed is that if you have good shared decision-making, you have better adherence to medications. If you have better adherence to medications, you have fewer trips to the ED. You have fewer asthma flares. There's been some studies that show that costs go down because patients choose less invasive options when they truly understand the risks and benefits. And this last study shows that there's evidence that shared decision may help our disadvantaged patients more than it helps some of our other patients, which kind of makes sense. If you think about two patients, and one is a college professor, and the other is somebody with low literacy or a homeless gentleman, the college professor is going to ask about her options. She's going to ask about your decision-making. And you are naturally going to engage her in decision-making more than the other gentleman. So if you are taught to engage people and you make a point of engaging people in decision-making, he's going to see a change in his care more than she's going to see a change in her care. Does that make sense? For every positive study, there are a number of negative studies. And the problem with that is that shared decision-making is really hard to study. We got to get each other to do it, and we got to do it well, which can be really hard to do. So we're going to start to talk about that. But studying it is also really hard. What are the outcomes that are important to us? How do we measure those outcomes? How do we make sure it happens in the context of the study, in the context of real life? And reality is really, really messy. And so studying shared decision-making in reality can be very hard. So this is what I try to do every day. So we designed a study outside of reality so we could ignore the issues of reality and try to show the benefits of shared decision-making. And what we did was we took 800 participants and we told them a story of something that happened to them. Everyone got the same beginning of the story. You have belly pain, you didn't feel good, it was a Saturday, you went to the emergency department. The doctor did some tests, and then at that point, the 800 people were split into 3 groups. Okay, so they got their story. The first group had no shared decision-making. The doctor came in, said, your tests look good. I don't think you have appendicitis. I'm not going to do a CT scan. Come back if you're feeling better. Okay. The second group got shared decision-making. The doctor came in, said, your tests look good. I don't think you have appendicitis. But you know what? It's possible that you do. There's always a very small chance. We could do a CT scan. Here are the risks and benefits of a CT scan. And the patient and the physician decide together that the patient feels fine going home, and they go home. In the third scenario, more shared decision-making, a more thorough conversation about all the risks and benefits of a CT scan versus no CT scan at this time. So no shared decision-making, brief shared decision-making, and thorough shared decision-making. And then everyone got the same conclusion to the story. The conclusion was, you went home, you felt worse, you came back, you were discovered to have a ruptured appendicitis. You needed to go to the operating room, and the surgeon told you after the surgery that, well, there was a delay in diagnosis, and because of that delay in diagnosis, you have a bigger scar, you have a longer recovery, and you're gonna be out of work for 6 weeks. So it's made clear to all the participants in the study there was a delayed diagnosis. And then they were all asked about how they felt about that first ED visit in terms of trust, fault, blame, and liability. And what we found was that the patients exposed to shared decision-making were 80% less likely to consider contacting a lawyer. Which is a pretty profound difference, but kind of goes along with what we thought about shared decision-making. And when we asked them about trust in physician was way up in the shared decision-making groups. The orange and the gray are the two shared decision-making groups, and the blue is the no shared decision-making group. Way up on trust, way up on overall rating of the doctor, overall rating of care. All of the markers that we're interested in go up with shared decision-making, and liability went down. And that's why all of these organizations, despite the fact that we have evidence for shared decision-making as well as evidence that isn't so great, feel like we should be doing more shared decision-making, and Baystate is on board as well. We want to increase the amount of shared decision-making that we're doing. Because again, nothing about me without me. Makes sense, right? So let's talk about how to do it and how to do it well, all right? So a few steps. Step number 1 is acknowledge a decision needs to be made. That's also called fostering choice awareness, okay? Let the patient know that there is a choice. We could do this or we could do this. Now, we can do this well and we can do this poorly. If you go to a patient and you say, I don't know what to do, well, we could do these things. They lose confidence in you, okay? So the way that we do this in the emergency room is we say, we have 2 options. The reason we have 2 options is because, you know what? If you were sicker, we would definitely need to do this. And if you were younger and healthier, we would definitely let you go home. These are the reasons why we are on the fence for this. So explaining why we have 2 options as opposed to saying, we have 2 options, and normalizing it. And our patients will get more and more comfortable with this the more we have these conversations, the more we normalize these conversations. So making it clear that a decision needs to be made that we're going to make together, okay? And then our job is to present the options. But we don't just say, okay, the options are a CT or an ultrasound, because that doesn't mean anything to patients. Our options are a CT and an ultrasound. This is what a CT would mean. There's a little bit of radiation. It's going to be a little bit of a higher cost for you or your insurance. You may be stuck in the emergency department a little bit longer because it takes longer to get a CT scan. And sometimes CT scans find these things called incidentalomas, which just cause anxiety and don't actually help us. All right? So you're telling the option and the consequences for the different options that you have. Now, at this point, we need to check understanding. We're not always very good about this. Our patients are pretty good about smiling and nodding because, again, that's what they have learned to do. So we need to check in and make sure that they actually understand what's going on. And this can take some time. So stopping and pausing and saying, do you understand the options? Is the shortest way to do it. A better way to do it, if you have time, is to say, you know, I'm not sure I explained that as well as I could, so you're putting it on you. Could you just explain that back to me so I can make sure I'm explaining it well? And that way you're not testing their knowledge, you're testing yourself. When you're explaining to them, you're testing yourself, all right? So you're checking for understanding. Next, you're gonna elicit their values and preferences. And this can be challenging as well. Our patients do not sit at home thinking about, what are my values and how do they affect my healthcare decisions, right? So they don't even know what you mean when you say, what are your values and how do they affect this decision? You need to tell them the consequences, the options, and then ask them, how do you feel about those consequences? Where do you see yourself fitting when it comes to the risks and benefits of this particular decision? You have to dig in a little bit. And then you are going to help make the decision with them. And then you want to support the decision. And all the patients we talked about how they were happy to make decisions, but they also wanted the doctor to support them in such a way that says, yeah, I think that's a good decision for you. They didn't want to make a decision and then feel like the doctor was saying, yeah, I guess that's okay, right? So support them when they make that decision. Now, it is definitely going to happen that the patient is going to say to you, well, what would you do? And there's an answer for that. First of all, it is not a failure of shared decision-making if they ask you what you would do. You are the expert. You have a lot of expertise, and they want your expertise. But you have 2 questions when they ask you, what would you do? You want to know, what would I do if I were me, or what would I do if I were you? Because I know my own values and preferences, and so I can maybe answer this question for me, but I'm not 100% sure that I know your values and preferences. So if you help me figure out your values and preferences, I can help you answer as if I were you. Does that make sense? All right? Because you don't want to necessarily answer it for yourself. You want to answer it and help them answer it for them. But by saying that, answering it as myself or answering it as you. And you can explain how you would answer it as yourself. You can say, well, if I was feeling better, I do have a primary care doctor, and I'm not particularly an anxious person, and therefore I would be okay with going home. Or, I would be pretty worried about this, and I would want to be admitted to the hospital. I would want to do this option, okay? All right, now we're ready to move on to part 2 about shared decision making. So we're going to be talking about how can we expand shared decision making and use it with each and every patient encounter. Now, if you remember from part 1, we defined shared decision making as the clinical scenario where there are 2 medically reasonable options. And the clinician explains the risks and benefits and the consequences of the option to the patient, and patients bring their own values and preferences, and together they make a decision. So that we're going to call classical shared decision making. In part 2 here, we're going to talk about our ability to use shared decision making in some different scenarios. So why would we want to use shared decision making as much as possible? So shared decision making has been shown to benefit the patient experience. We see this in our Press-Ganey scores. I see this every day in my clinical work. And it just makes sense. If you are someone showing up in the emergency room and the emergency room looks and feels like this, and the ICU feels like this, and you know what? Sometimes even a doctor's office feels like this. You are outside of your comfort zone. You are out of control, and you're in a place where things are happening to you, to your body, to everything around you, and you don't have control. So shared decision-making is a way of giving people some control, respecting their autonomy in a place that they're not used to. So we're going to illustrate our points through a quiz. So here's the beginning of the quiz. Walking to the door of the patient's room, whether it be in the emergency room, the ICU, or an office, and knocking on the door and saying, "May I come in?" True or false? This represents shared decision-making. Anyone? So it doesn't really represent shared decision-making in the classic definition that I just gave you, right? There's no 2 medically reasonable options. They're here to see you. You know you're going to go in. But it does address some of the same goals as shared decision-making, right? So what does it say to someone when you knock on the door and you wait before you go in? Because I know I'm guilty of knocking as I'm walking in. When I knock on the door to someone's room, even if they don't have a door and they just have a curtain and I'm knocking on the side, and I wait till they give me permission to come through the door, it says to them, this is your space right now, and I respect that that is your space, and I'm not going to come in until you tell me it's okay to come in, okay? You are giving them an aspect of control over their care. We're going to move on to question 2 of the quiz. This one's a multiple choice question, so you have to listen to a couple of stories. So this is story A. It's about a gas meter. So last summer, I was about to leave for work. It was about 8 o'clock in the morning, and there was a knock at the front door. So I go answer the front door, and there is a guy from the gas company, and he's been there before because he had to be in the basement for some stuff they were doing. He said, "We have a decision to make." And I said, "Okay, I got to go to work in a few minutes, but all right, what's going on?" And so he brings me outside, and he said, "We are moving all the gas meters to the outside of the houses so that we don't have to access the inside of everyone's house when we need to get the gas meter." I said, "Okay, fine, that makes sense. We have to decide where the gas meter is going to go." Okay, he says, "I'm thinking that it should go right here." And I'm right here, right next to the front door? Yeah, right here, right next to the front door. And I am not thrilled by the idea of the gas meter going right next to the front door. And I said, "What about the other side of the house?" And he said, "Let's go take a look." So we marched around to the other side of the house. And I said, "How about right here?" And he said, "You know what? I thought about that spot. But remember when I was in the basement the other day, I looked at that spot and it wouldn't be possible to get all the piping over to this side of the house." And I said, "Oh yeah, that makes sense. I know where the gas meter is on the inside of the house." I said, "Let's go look at the other side of the house." He said, "Let's go look at the other side of the house." So we march around to the other side of the house. I'm like, "What about over here? This is hidden by bushes. It's on the side of the house." And he said, "Yeah, I thought about that, but you've got that crawl space in the basement. So I couldn't actually get everything that needs to get here. We couldn't make it happen." So I said, "Yeah, I guess it's probably going to go on the front of the house next to the front door." And he said, "Yeah, I think it probably is." All right, so that's story A. Story B. Story B is about a gentleman seen in the emergency room at Baystate. True story, 55-year-old, syncopized, and we met him when we were doing one of our surveys. So the first part of the survey, we asked people about their opinions and their attitudes. And then the second part of the survey was only filled out after the decision about admission versus discharge had been made at the end of the visit, because we wanted to know whether shared decision-making was happening during the visit. Now, in this gentleman's case, we happened to be in the room doing the first part of the survey when the resident, who was a well-respected senior resident, came in to tell the patient the plan. So he came in and he told the patient, your tests look good. We're going to admit you to the hospital, probably just for monitoring for 24 hours because you fainted. And the gentleman said, oh, I really didn't want to be admitted to the hospital. I was hoping to go home. And the resident said, well, we would never admit you against your will, but this is why I think you should come in. I'm hopeful it'll only be 24 hours. We'll do some monitoring and then you'll probably be able to go home, but we'd never admit you against your will. The patient said, all right, that sounds good, doc. And that was the end of the conversation. And then he filled out my form, all right? And my form had questions like, the doctor made it clear to me that we had a decision to make. And he gave him a completely agree. The doctor made it clear to me the consequences of the two options. Completely agree. The doctor and I made the decision together. Completely agree. Okay, so that is story B. Story C is about a friend of mine who is a primary care doctor. So these are all true stories. He is a wonderful primary care doctor. And like many of us, in the winter, he sees a lot of patients with coughs and colds, all right? And to make sure we're on the same page, the colds that we see all winter generally do not require antibiotics, right? But many of his patients come to him hoping for antibiotics. He is fortunate in that most of his patients are pretty healthy. They're not actually that sick. And they come in hoping for antibiotics for their cough and cold. And when they want antibiotics, he starts his conversation with, I'm happy to write you a prescription for antibiotics. Let's talk about the risks and benefits of taking a prescription of antibiotics right now. All right, last story, story D. If you're looking at our slides, this is a kidney bean that is a hero, just in case you couldn't tell. So this is a story about a nephrologist at Baystate who received a very nice letter from a patient's wife. So the patient had chronic kidney disease and was going to the nephrologist for the first time, which I can imagine could be scary. And the patient's wife wrote a letter and said that the nephrologist kept saying a few things that, in her words, increased the patient's adherence 100%. He said, if it's okay with you, what I'd like to do next is, and with your permission, this is what I think we should do. So the question for you is, which of those stories represents shared decision-making in the way that we have discussed it? So let's talk about our syncope patient first. The doctor who saw the syncope patient had no intention of doing shared decision-making. When I took the shared decision-making scale back out to the doctor and I asked him, hey, which of these did you do? He looked at it and he said, I didn't do those. I didn't mean to have shared decision-making. But in reality, he acknowledged to the patient that he always did have an option. He had the option of not being admitted. He had the option to disagree with the physician's care plan. And we all know that we have that option, even if we don't think about it consciously. We know as clinicians that if we go to our doctor and our doctor has a plan and we don't agree with that plan, we just go get a second opinion, right? Or we just don't do it. And you know what? Our patients know that too. So if we look at who fills prescriptions, we know that a ton of prescriptions don't go filled. Some of that's cost, some of that's I lost the script, and some of that is when the patient took that prescription from you, they had no intention of filling it. They smiled and they nodded because they knew that they were supposed to do that. Well, what if you had engaged them in a conversation when you gave them that prescription to find out whether or not they actually wanted that prescription? You might have discovered that they weren't going to take it because of this, and maybe there's another option, and it could be this, all right? So the moral of that story is that our patients always have a choice. And what we need to do is acknowledge that and put that power in their court. Listen, you always have a choice. This is what might make sense at this time from my perspective, but I get that you have a choice. We have patients who leave against medical advice. Sometimes it's for reasons we disagree with, but it's their reasons, and they are valid people with their own ideas about what is important at that moment of their lives. When we acknowledge that, we sort of expand shared decision-making a little bit. The gas meter guy, story A. So I am pretty sure that the man from the gas company knew where he was putting the gas meter. Only in retrospect, but in retrospect, I say, I'm pretty sure he knew where we were going to put the gas meter. But he made me feel heard. He made me feel like he had actually looked into those options. And I fully understood why we ended up with the gas meter where it was, right? It wasn't just like, hey, it's going there. And I was like, what the heck? So having a choice or feeling like I had a choice, even though I didn't, felt good. This also works on children, right? You give them a choice, which do you want to eat first? Do you want to eat your broccoli first or do you want to eat your potatoes first, right? You give them a choice because feeling like they have a choice feels better than saying, eat your broccoli, all right? C, our cough and cold and antibiotics. So I have to tell you the end of the story. When this primary care physician says, I'm happy to write you a script for antibiotic, let's talk about the advantages and disadvantages, almost no one takes him up on it. His patients hear him when he says, I'm happy to give you a script, and then they listen to him when he talks about the advantages and disadvantages, and then they make their own choice. So from a classic shared decision-making, there's no equipoise here. There are not two medically reasonable options. Antibiotics are not good for you if you don't need them. They cause diarrhea. They cause antimicrobial resistance. They cause all sorts of problems. But for a primary care physician, for whom adherence is important, right? If they trust him and they listen to him and they have a good therapeutic relationship, they are more likely to take their diabetes medications. They are more likely to take their hypertension medications. And he recognizes that although the benefits of antibiotics may be just emotional or relationship building, those are still real benefits, right? And we know that all over the country, there are clinicians prescribing antibiotics for non-medical reasons, right? And we probably shouldn't be, but there are reasons we're prescribing them, even if they're non-medical. By starting with, yes, his patients listen to him and they end up with the best medical care because they feel heard and they hear him. Our last story, D, what do we learn from our nephrologist? What I learned from the nephrologist interaction is that we really can frame everything as shared decision-making. If there is something that we need our patients to do, we still can talk to them about it as a choice. There are options. I think this one might make the most sense for you, and this is why. Frame it as a choice, and people feel empowered, and people feel better about it. So putting it all together, what can we do in our practices? Very simply, we need to talk about shared decision-making. Talk to your colleagues. Where do they use shared decision-making? Maybe they use shared decision-making in a way that you hadn't thought of. Where do you use shared decision-making? Where could you use shared decision-making? Formalize situations. Do you talk about colonoscopy versus fecal occult blood testing a lot? There are decision aids for that. Are there decisions that you talk about a lot that there are not decision aids for? That's fine. Talk to your colleagues, get yourselves on the same page. And then consider how to expand shared decision-making. What are the little decisions that you make every day that you can turn into this expanded shared decision-making? Whether that's knocking on the door or deciding to say something differently. This is what I think we should do, but let's talk about it. This is what I would like to do. I'd like to know how you feel about it. How do you feel about the option of this? Putting it in the words of shared decision-making, even though there may not be any medical equipoise. All right? I'm going to leave you with a very last thought that sort of sums all this up for me, which is that people don't remember what you said. They remember how you made them feel. So if they go to the doctor and they feel involved in decision-making, they remember that. And that builds a therapeutic alliance, not just with you as the clinician of that moment. That builds a therapeutic alliance that they hopefully will carry to the next physician and the next physician and the next physician. So the more we do this, the more we are building trust in the healthcare system, which is something that a lot of our patients don't have. Thank you very much.